Allison. Thanks for joining us tonight.
Thank you so much, Andrea. Thank you everybody for being here with us tonight. I appreciate you guys coming and joining us in this virtual webinar in the middle of the week, kind of late at night. So we're really excited to have you guys all here. As she mentioned, my name is Allison Biliti. I currently serve as the Southeast Region EMS Coordinator for the state of Michigan in the Bureau of EMS Trauma and Preparedness. Prior to this role, I worked as a critical care field paramedic for a suburban private EMS agency. I also served as a program director for initial NCE sponsorship program. Currently, my position also awards me the opportunity to work as the National Registry of Emergency Medical Technicians ALS psychomotor exam rep for the state of Michigan. So I'm pretty well-versed in delivery of psychomotor exams. I'm really excited to share this information that I have here with you guys today. Very passionate about EMS education and this topic in particular. So thank you. We're going to talk about inter-rater and intra-rater reliability tonight, and really what that means and how we can apply that in programs that you guys might be involved in. Assessment in EMS education is an evolutionary process that is determined by each individual EMS program. So each program is really determining what that assessment is going to look like. But the autonomy of that is definitely authorized through national accreditation standards and state guidelines, which allow programs to determine those assessment tools and the assessment practices that they will use to facilitate the meeting of student learning outcomes. Even with the autonomy, formative and summative techniques, and we'll talk about what both of those mean in those terms here in just a bit, but those should be done and employed in both didactic and psychomotor arenas in EMS education programs. So kind of what we've already known up until this point as far as EMS education, we need to have both didactic and psychomotor learning, but we also have to have assessments or evaluations in the didactic and psychomotor arenas. The major objective for EMS education, just as a reminder for folks, is to prepare students for entry-level practice in emergency medical services. So that's an important key, entry-level practice. And what does that mean? We don't expect students to come out and practice at an experienced provider level. So we need to make sure that when we are in an evaluation setting, that we remember that and that we evaluate for entry-level provider practice. Today, we are going to discuss, like I said, inter-rater and intra-rater reliability of EMS evaluators specifically, and how they rate EMS student performance on those psychomotor skills or during a psychomotor exam. So our objectives, certainly we want to make sure we know and understand the definition of both of those terms, inter and intra-rater reliability. We'll talk about the importance of those and the value that they might hold when we're delivering psychomotor evaluations in initial and even in continuing education settings. We'll talk about how we can achieve higher inter-rater reliability rates and improve techniques to improve our inter-rater reliability. How we can perform objective evaluations as evaluators, if you find yourself in that evaluator role, and how do we evaluate our inter-rater reliability? What is it, but how can we determine that within our own program? So those are some of the things that we're going to talk about today. But to start, we're going to start with the basics here. What is an evaluator? So an EMS evaluator is responsible for the evaluation of skills within their own scope of practice, and also They provide skill proficiency verification. So the autonomy that's provided by the state of Michigan for them to verify skill proficiency for these entry-level providers. The final exam, if you will, takes place in their programs. And these evaluators are responsible for making sure we have proficient providers. This does take place in a variety of settings. So individual or formative evaluations are skill evaluations that happen throughout a program. So evaluations in the initial MFR or EMT courses. Think about right after you learn a skill for the first time, it's practiced and practiced and practiced. And then there should be an assessment or an evaluation of performance on that individual skill. That's a formative evaluation. This also takes place in end of course evaluations, also known as summative evaluations. And as the name suggests, these happen at the end of the course. And this is kind of a continuation of not just one skill, but all of those skills in the initial MFR and EMT course. And then evaluations also occur as needed for traditional CME recertifications. I mentioned a minute ago that these evaluators, an EMS evaluator must only observe within their scope of practice. So what do I mean? They must be certified or licensed to perform the skill that they are evaluating. Okay, so they have to be certified or licensed at that level in order to perform an evaluation of that skill. EMS evaluators are responsible for providing fair, reliable, and objective practical skills evaluations. These evaluators should be carefully, I'll stress the word carefully, selected based on their skill expertise and ability to fairly and accurately observe and also fairly and accurately document various performances during a skills examination. They must also be competent in both the performance of and the ability to properly evaluate each individual practical skill. And this has to be ensured prior to an evaluator evaluating another person's ability to perform the skill. So what do I mean here? They must know how to perform the skill that they are observing. And you can't have an evaluator evaluate somebody else if they aren't operating at mastery level of that skill. They should know how to use the clinical equipment that is required for that skill, and not only know that, but also have mastery in that clinical equipment. And they should also know how to complete the evaluation tool that is being utilized. And sometimes we forget that it's really all three of those things together that make a good evaluator. And we'll talk about those again here in just a bit. But I want to mention this next topic is the certified evaluators. So there are actually several states that require an evaluator certification. Okay, certification process includes application. So they have to apply to become an evaluator. There is a rigorous training and even a testing process that has to be conducted and completed in order for them to be even considered an evaluator within any EMS program or any examination that occurs in those particular states. Now, this is not a current practice in the state of Michigan, right? There is not an additional certification that we can achieve to become a certified evaluator. I will point out that the reliability data remains consistently higher in these particular states who require this as an additional certification. Okay, so their reliability and their exam evaluation delivery is higher than states that do not have a process in place. So what are some characteristics of good skill evaluators? So not just skill evaluators, but good skill evaluators. Well, they know and they watch for critical errors, right? That's part of what they're doing when they're evaluating. But they're not just evaluating to make sure that they're hitting all of the required components or the required checklists. They're looking for things that happen outside of that or anything that might be critical to patient outcome. That's a good characteristic. They also accept, this is an important one, that there is more than one way to complete a task correctly. And this one's a tough one for people to sometimes grasp and for us to understand and really apply. Okay. It's such an important concept when it comes to reliability. Not everybody is going to perform a skill at the same level. Okay. And that's okay. Right. Not everyone will complete a skill the way that you would. And that's okay too. Not everyone's going to do it the way that you were taught. All of those things are okay and they are acceptable. And if you can understand that and put that into practice when you are evaluating, you will come out as a better evaluator, knowing that it's okay to have variation in the degree of performance. In fact, good evaluators will actually be able to use professional judgment even with a standard scoring system that we have, and we'll talk about our standard scoring system, because they will know that there are multiple approaches that can be taken by any student to fulfill the testing requirement. There's more than one way to get to that end goal. And if you are a good evaluator, you can use your professional judgment to say that this is an acceptable performance or to say that this is an unacceptable performance. They keep things positive. Okay. They should be aware of the fact that students who are coming into a testing setting are often nervous during that testing situation. You know, think about all of us, we've been in their shoes before, and we need to try and make sure that that environment is a positive environment. Positive environments always lead to better outcomes. They are fair and impartial and also objective. All evaluations should be conducted on an equal basis. They should have set responses. The correct response does not vary from one student to the next. And the evaluations must be based on fact and not feelings. They are consistent and reliable from one evaluation to the next. This is the concept we're going to kind of dive into here, but that is inter-rater reliability. From one evaluation to the next, they are consistent. And they avoid labeling students. They should pay particular attention to eliminate actual or perceived discrimination based on any potential discriminatory factor. Things like age, race, sex, gender, religion, any of the above, right? They really consciously make an effort to avoid allowing any bias affect their ability to evaluate objectively. And certainly they should work professionally. I say this almost as if we don't need the reminder, but unfortunately, I have seen firsthand instances where we do need this reminder. In fact, I personally believe that just like EMS educators, evaluators should be held to a higher professional standard. Okay, and they should constantly look to seek self-improvement. Just because you have evaluated skills on multiple occasions doesn't mean that you can't become a better evaluator and improve on evaluation theories and evaluation methodologies. So there was a research review study that was conducted several years ago in the state of Michigan. And several years ago, this was dating all the way back into like the late 90s. Okay, the study was done. And what they did was they took a look at specifically evaluators and the current methods of evaluating Michigan EMS licensure candidates. And the evaluators that this study reviewed were licensed EMS providers. They were licensed from the EMT level to the paramedic level, and they were conducting observation assessment of the EMT licensure practical exam. So anybody EMT through paramedic license evaluating EMT final psychomotor exam students during the study. What they conducted or concluded, excuse me, was that the evaluations were actually subjective. They were potentially unreliable. They found that there were often notable variations in scores given by the evaluators for a single observed student. So when those evaluators viewed the same student, there were significant variations in scores. There was too much variation and not enough observational consistency. All of that combined with low levels of evaluator agreement about skill performance suggested, and from this study, they concluded that evaluators do not reliably rate student performance during practical evaluation. Now, a couple things I want to point out. This study was done quite some time ago, and we have had a vast growth in our education process and also our evaluation process. But evaluating these skills must be a valid process that clearly identifies those students who can and those students who cannot perform a skill as required. In no instance should we have multiple evaluators assessing the same student and coming out with different results. And that's what we're talking about today. How do we achieve the same results and how do we make sure that it's consistent and it's valid and it's reliable? I can also tell you that there is not much information recently related to our evaluation methods that we use in EMS education now. And that is with the exception of the NREMT skill sheets, which obviously have a long-standing vetted data-driven validity related to them. So the skill sheets that we're using has a lot of great data, but outside of that, there isn't information relating to the evaluation process and the evaluators that we're using in these psychomotor evaluations. But there's good news. The good news is that there is some really good analytic attention and information regarding the reliability of assessment, so psychomotor exams in other health professions. So there's data and research on the validity and again, the reliability of evaluators testing other health professions. And this is good news for us. Because remember, our goal of EMS is to develop competent entry-level providers. So if we can take the findings from these other health professions about reliability and validity of their evaluations, and we can apply them to our own EMS psychomotor evaluations, we will ensure that we are meeting our goal, that we are evaluating these candidates and these students for entry-level provider proficiency. It's essential to have quality assessment strategies in place prior to delivering the psychomotor exams. And also, another really key important piece, to have properly trained individuals to utilize those strategies. So we have to build a program to say, this is how we're going to ensure reliability and validity in our evaluations of students. But we have to make sure everybody knows what that is. You know, you can't have a plan and not tell everybody how that plan is supposed to work. So we also have to have educated and trained professionals utilizing those strategies. And what I mean is educated and trained professionals evaluating these students in the psychomotor exams. So inter-rater reliability. Okay. Inter-rater reliability refers to the extent to which two or more individuals agree. It is applied in situations where different assessors or raters, or in our case, we're going to use the term evaluators, different evaluators provide judgment on the same target, the student. Okay. And consensus would exist in the scores given by various evaluators. So what do I mean? I mean that they're all on the same page. Okay, so we talked about that study that was done back in the late 90s. And when we have multiple evaluators evaluating and assessing the same student, we should have consensus and consistency from one to the other. If a student were evaluated by multiple people, the score or the rating of the performance would be it would be the same, and it would have an identical judgment. And that's what we're looking for. And that right there tells us that the exam is valid and reliable and a good indicator of measuring entry-level competency. Chances are inter-rater reliability has come up before. You've probably seen it in action and you just maybe didn't know it. A great example that I can use outside of EMS evaluation is any sport that uses judges. Okay, specifically, I'm going to give you the example of the Olympics. Okay, so during an Olympic sport or an Olympic event, scoring relies on human observers, and those human observers have to maintain a tremendous degree of consistency between the observers. If one judge is erratic in their scoring system, it can jeopardize the entire system. Okay. And it can jeopardize or deny a participant their rightful outcome. So in the case of the Olympics, it could deny a participant potentially a winning medal. Okay. In the case of EMS evaluators, if we have evaluators who are not consistent, again, it could jeopardize the entire system, the entire psychomotor exam testing process, but also deny a participant who would have been considered an entry-level competent provider. Outside the world of sports, obviously, is what we're focusing on, and that inter-rater reliability has far more important connotations and can directly influence the EMS education programs. Obviously, the EMS student outcomes, I just gave you an example. You know, we could have an entry-level provider who, if not scored consistently, might not achieve that positive outcome or that end outcome. And certainly that in itself can ultimately affect the EMS system throughout the state. If we aren't using reliable evaluations for psychomotor exam testing, and we are missing folks who are entry-level providers, you know, those are providers that we are not gaining in our profession. And we already know that we have a drastic shortage in EMS providers within our state, with nationwide, as we know the shortage extends. But we really want to make sure that we're capturing all of those folks, because we're evaluating them valid exams and valid evaluations. For us as EMS educators, you know, it's important whether you are the program director. If you are a program director and you are responsible for gathering and providing evaluators for all of the psychomotor testing within your program, this is important to you. If you are not a program director and you just may find yourself as an evaluator one day, this is also important to you. Okay, having an inter-rater reliability process that is robust and ensures that the generated results will meet the accepted criteria for reliability and validity affects us all. It affects everybody in EMS. And this is an important thing that we make sure we're implementing at the education level. So how can we achieve higher inter-rater reliability? Okay, I mentioned that analytical information from other health professions, because remember, we don't have a lot of research and data in the EMS reliability realm. So we have to take that information from these other health professions and use that as our own framework. Many of those other research programs concluded kind of these best practices, if you will, to help achieve a higher inter-rater reliability. So the use of standardized forms, extensive training, monitoring the IRR, which is an abbreviation for inter-rater reliability, and standardized patients and scenarios. So almost all of the data that I looked at concluded the same things. These things are really critical to us achieving a higher inter-rater reliability rates. We'll take a closer look at each one of these. The use of standardized forms. So in the state of Michigan, it is a current practice, and in fact, it's a current requirement to utilize the National Registry of Emergency Medical Technicians skill sheets. Okay, this has to be done at the summative level. So that end of course testing has to be done utilizing the National Registry skill sheets. The National Registry skill sheets are a tool that have been developed and vetted by professionals, and they reflect years of experience in examination administration. I mentioned before that the research and the data, all I could find was the research and data relating to the development of those skill sheets. They were developed as checklists. Okay, so we know that the psychomotor skill sheets are checklists, but the reason they were developed was to standardize that assessment criteria with a grading tool to reduce subjectivity. So one of the things that we need to look at to achieve a higher inter-rater reliability is objective evaluation. And the tool, those skill sheets were designed for just that, to create objectivity, remove that subjectivity, remove that human factor almost, if you will, so that we have objective evaluation. It uses a very clear grading rubric with explicit criteria, and it provides the evaluator with the important concepts that are being evaluated. And this is good news, right? So good news for us that the fact that this is a requirement to utilize these skill sheets. This means one less thing we have to come up with and develop on our own if we're concerned about resources and time and money and all those things. Utilizing these skill sheets is beneficial. I will say, however, that these skill sheets were designed to be a summative evaluation, that end of course evaluation, and they don't have skill sheets for every skill that should be taught throughout initial MFR or EMT programs, right? And so programs, or you guys as ICs, might find yourself still having to develop some really good standardized objective forms for skills that we don't have skill sheets for presently. So things like an example, a CPAP, for example, there is not an NREMT skill sheet for CPAP, but that is a skill that would be tested at the formative level throughout the program, making sure that they have proficiency as they move throughout their program. Intranasal medication administration, it's a big one, right? And that is part of core curriculum and something that should be formatively assessed throughout the program. Again, not a skill sheet provided by the National Registry. So the pitfall is that we've got these great sheets and they're available to us, but we don't have them for all of our skills. So what do? Right? We should be developing these and making sure that they are standardized, they are reliable, that they are providing us with the important concepts for that particular skill, and that they are validated for a tool that can be used with a reliable assessment. Evaluator training. So this is a really big key concept and probably the most research out there that you will find regarding inter-rater reliability. As educators, we often assume that our evaluators are reliable based on experience alone. Okay, if you have a license, you should be able to evaluate, right? Or because of a lot of folks that have limited resources in education, okay, they might have found themselves in a position where you're walking down the hall and you're in need of an evaluator. So you grab the person who's coming off a shift and you say, I need you to stay and evaluate for a couple hours. Is that a best practice? Absolutely not. And we really have to have evaluators who aren't just picked based on experience, who have worked in the field for 10 years, so we're going to use you. If we couple that with the fact that we usually put them in that seat without any type of orientation. Okay, so I need you to stay for a couple hours. Maybe we've enticed them with some food options, and we say, oh, well, we'll feed you if you stay. That's great and all, but that doesn't help them become more effective when they're evaluating these students. So instead, we bring these people in based on experience. We provide them very little guidance, very little orientation. If we do orient them, sometimes it's just very basic, and we may go over a quick review of the evaluation form. Here's the skill sheet that you're going to be using. Let me know if you have any questions. This is not sufficient enough. Okay, evaluators, particularly those without training, frequently end up using their past experience as the basis of their interpretation of a student performance. Okay, so regardless of how well written and how clear the skill sheets are, those performance standards are, they are interpreted by the evaluator based on personal perception. Okay, my own past experience. And that's really not an objective evaluation. There was a study done a few years ago, and not quite as long as the other one, but a few years ago, and it determined that direct observation evaluations are actually often influenced by interpersonal relationships that exist between the student and the evaluator. Okay, so I'm not talking about, I don't mean personal conflicts of interest. So not like my partner is the student and I'm evaluating them, or my roommate, or my cousin, or my brother. None of those things. I'm not talking about personal conflict of interest. I'm just talking simple interpersonal relationships. And I'm actually referring to a student and evaluator who have not previously met prior to observation. And what this study found was that evaluators would score students more favorably if they performed the skill in the same way that the evaluator would. Okay, so this is known as the similar to me effect, or sometimes called the halo effect. So if I'm evaluating somebody and they perform that skill just like I would perform it as an experienced provider, then I would score them more favorably. But if I have somebody who performs it in a different way, remember we talked about this concept earlier, and not the way that I would do it, right? Then I score them less favorably. Okay, and that's what the study found. And really, this is adding that subjectivity back into evaluation. It's doing the opposite of what we want, right? We want it to be objective. We want to remove that similar to me or that halo effect. We want to remove all of that interpersonal relationship, and we want to have objective evaluators. So in order to get there, we need to train them. We need to develop a training program for evaluators to prepare them in evaluation skills. Okay, skills that they don't learn in their clinical provider classes, how to become an evaluator. This training can be accomplished in different ways. It should be left up to the program. Obviously it would be specific to resources and needs. Maybe you want to do a face-to-face training or an online training. I'm going to throw that out there. I don't know who in EMS has all the money in the world, but there are private resources. There are actually independent consultants who specialize in this exact training. And if you have the resources to bring one of those people in, that would be fantastic. Provide training on how to evaluate and evaluation skills. However, the delivery, the training has to happen. We know that, right? High quality evaluator training should also not be a one-time or maybe just a several day event, right? It should not be one time and you're done forever. It should not be come to these 3 days of training and you're good. There should be training, ongoing learning beyond that initial training session. And that ongoing learning should take place in a variety of venues, a variety of formats, and it should give them the opportunity to grow as an evaluator. Okay, so we talked about the importance of proper evaluator training, right? We need to make sure we train them, because without training, we're relying on subjectivity, and we definitely don't want that. But unfortunately, with little research in the area of EMS evaluation, We do not yet have a system in place to provide consistent, high quality training across the state. But again, taking that framework from other health professions, we can build a training that focuses on specific valuable evaluator skills. And we can modify that and we can adapt it to our own personal needs or our own program needs. So some of those things that we should include in our evaluator training. So what are these key framework concepts that we want to make sure are part of our training? Well, the first thing is outlining expectations. Evaluators cannot perform in a way that we expect them to if they do not know what that way is. If we don't tell them, we are really providing a disservice to them because they don't know what they don't know what they don't know, right? So we need to tell them, what are the expectations? We should lay them out very specifically, and we should do this often. Okay, remember, this is not one time. I'm going to give you an evaluator training and I'm going to say, this is what I expect of you. And then 6 months, 7 months, a year goes by and I bring you in to evaluate, and you may not know what those expectations are. You might not remember those. Obviously, you guys know the concept that if we aren't putting something into practice daily, we're going to lose that information. So we want to make sure that we consistently remind folks about what our expectations are. Help them understand and apply the assessment tool. Okay, that the skill sheets or the grading rubric. Okay, that is important for this training when we want these evaluators to be good evaluators. We're going to train them on those rubrics, but we want to make sure that the focus is on how performance indicators are interpreted and how to apply that observation and not simply what they are. Okay, what do I mean? We don't want to just recite the skill sheets step by step. Okay, they can read those on their own. We want to train these evaluators and show them how to identify and understand what the skill steps look like and what they look like at different levels of performance. So it's not, performs a airway maneuver. Skill check, right? I'm not telling you that. I'm showing you this is what you might see. And I encourage you, if you're building a training program for evaluators, to train your evaluators on what those indicators look like at different levels. Okay, not every candidate comes in and is an A or 100% student, right? Those are the easy ones to evaluate, in my opinion. The hard ones are the folks who come in and they're not 100%. And unfortunately, we don't do a really great job of training people on what that looks like and how to interpret that. I'm going to use an example. We had a training at the state level where a video, and this was the ALS evaluator training, a video was shown, and that video was shown to a group of evaluators, and we asked them to evaluate the performance. Okay, and they did it independently, and then we talked about, what was the outcome, and looked at really the differences that we saw between evaluators. But the problem I always had with it is that the video we showed was 100% accurate. It was the student who came in and they did every skill step and they did it exactly like they should. It was the textbook example, and I really think, like I said, that was a disservice to folks who we put into an evaluator position where they have to interpret students who come in and don't perform at that level. So I would say the best thing that we can do is to show them those performance indicators at all of these different levels. What does a minimal competent entry level provider look like? And what does the evaluation of that person look like? Because really, that's what they're going to be doing. And that's where we see these opportunities of evaluators in a setting where they just revert back to that similar to me concept. And they just, if they don't do it the way I would, then I can't mark them. I mark them off. And we don't want that, right? We want to make sure that they know how to evaluate, the not 100% student. Okay. Rating the observation. So evaluators should be trained on exactly how to score the student using the rubric. So you're going to go through that rubric, that skill sheet, and they're going to use that skill sheet. Remember, it's a checklist format. Those are efficient, but they convey very little information. Okay, evaluators should be asked to document concrete, observable evidence. This limits the potential for bias. It helps the evaluator to justify their claims, and it provides us with objective feedback. Okay, so the training should also include a component assessing the evaluator's competency. Okay, I mentioned this before, right? The evaluator should have mastery of the skill that they are evaluating. You can't evaluate somebody else if you don't also have mastery of that skill. So simply participating in a training course does not guarantee mastery. Okay, just because I took the course doesn't mean I'm going to be good at this. So there should be a component built into your training program for the evaluator to apply the concepts that they learned and to evaluate. Okay, so this should be maybe an evaluation of an instructor. Okay, maybe they evaluate an instructor who's performing a skill. I gave you the example that we had a video recorded session where you can record it and you can ask them to rate their observation from a video. So it doesn't have to be an in-person direct lifetime observation. Okay, there are different ways that we can do this, but you can teach somebody something, and until you evaluate their understanding of that, you really don't know if they are going to be reliable when it comes time for them to use that in the psychomotor exam setting. We also want to monitor our own inter-rater reliability. So one thing to achieve greater success, we need to spend time monitoring what data is provided to us. You know, we should review it often, we should look for trends, and we should intervene early. During a psychomotor assessment, we should be reviewing the skill sheets, okay? And we should be monitoring the progress at each skill station. If you notice a trend, maybe a particular evaluator has failed every student. Okay, you need to investigate that, and you need to do that sooner rather than later. If I personally saw this immediately, I would think that we have an evaluator issue, not a student issue. Okay, so we need to look for those things. And I say to do that during that assessment, do it during the psychomotor exam so that you don't come out of it and could have had a problem that we could have very easily fixed. We should also be evaluating and analyzing this data after these exams. Go back through your skill sheets and go back and spend some time looking at your evaluators and saying, did we score this? Is there a reason why every single person with this one particular evaluator missed this? You know, that's valuable also for the other side of education, the didactic portion, because maybe it was something that we never taught. Okay, it's unlikely, but it's probably more likely that it's related to the evaluator, and that's something we need to address, right? We should analyze this data. We should establish some methods for ensuring that it's consistent and it's accurate every time we deliver a psychomotor assessment. We should also here, another best practice is use standardized patients and standardized scenarios. They should be established well in advance prior to the observation day, okay, prior to the exam session. These patients and scenarios should be established. The National Registry guidelines dictates that any live patient should be EMS related. Okay, it's recommended that they're EMS related. So think of like past students, current students, somebody who has some degree of knowledge in the EMS field. Now, it's not a requirement, but it is recommended. And certainly that would improve reliability in learning outcome or testing outcome and also evaluating outcome. It is required, however, that they must be greater than 16 years of age. If the scenario is specifically written for a pediatric population, a mannequin must be utilized. They should be average height and weight. Okay, average adult height and weight. And all of these things that these guidelines that have been developed ensure that we achieve consistency in testing and evaluation from one student to the next. Okay. The patients that we utilize should be standardized, right? Meaning that they perform or they present the same every time. They should be trained enough to accurately and consistently recreate the parameters of the scenario. Okay. They should be able to portray the patient as accurately as possible. But the key is also as consistently as possible from one student to the next. And we've got to make sure that reliability and fairness and impartiality occurs from one student to the next. And believe it or not, standardized patients can influence that, and they can influence it significantly. So it's really important that everything is already pre-designed prior to the psychomotor exam. The same thing with scenarios. Scenarios should be determined prior to testing. Ideally, this should be done by admin staff of the program. This isn't something we should remember. That evaluator that just got off shift, I said, come, I'll buy you lunch if you can come and help me evaluate. Oh, by the way, pick a scenario. Okay, that is not a best practice and not what we should be doing, although I know that it happens. The scenarios that we use should also be standardized, just like the grading rubric. Okay, they should be very clear, they should be specific, and they should be really well scripted. When the evaluator is delivering that scenario information, they should not deviate from the scenario, and they should not need to, because it's so well written and so well scripted. And it shouldn't allow for the evaluator to influence performance or ultimately the evaluation of that student. And that can, if they deviate from them. Evaluators need to remain consistent and fair. The safest approach to remain consistent and fair is, like I said, to have a really well-written scenario, to limit dialogue, keep it to exam-related material only. They should only be asking questions that are related to clarifying purposes. If you have a question about, what they're performing or a skill that they're performing, yes, ask it. But other than that, we need to remember that this is not the time for coaching or teaching students. And again, getting that consistency from one to the next. If you do that for one student and you don't do that for the next, we've lost our reliability. Okay, so that's why eliminating all of that and all those subjective additives is really what our goal is. There should also be a scheduled time for the evaluators and a patient, if we have patients, to become familiar or refamiliarize themselves with the skill sheet. So remember that ongoing training. They can't train today and a year from now come in to do an exam and we expect that they just sit in the seat and move forward. We need to have time built into allowing them to refamiliarize with the skill sheet, time for them to read the scenario, and time for them to ask questions, so that when we go into the exam and they begin evaluating, that we do ensure consistency and that there are no deviations. They should review instructions, briefing, moulage, equipment. All those things should be done before they begin evaluating. I have the NREMT website on here. The NREMT website is really a great resource for some sample scenarios. So I'm going to take us there, and we're going to kind of look at where you're going to find these resources. So this is the NREMT website. I'm sure many of you are familiar with it. The page that I'm about to take you to is a nice, because I don't have to log in. I don't have to remember my username, my password. I'm going to just simply scroll down to the bottom of the page. I'm sorry for scrolling, folks. And under this blue section where it says information for, I want to click on the one that says educators. So when I click on the information for educators, it'll take me to, obviously the page that was designed with educators in mind, things, quick resources and references that we can utilize. I'm going to click on this first hyperlink that says paramedic portfolio page. And when I do that, that takes me, I understand that this is the advanced psychomotor design right here, but these are concepts that you can apply at any provider level. So if you are doing an EMR or an MFR exam, and an EMT exam, you can use the information that they have built here because we know that it's validated and it's reliable information. So if we scroll down here, there's a tab that says scenario information. Again, we're going to click on that. There are some really great scenario and resource tools here, like drug dosage charts and medication label stuff. But I'm not looking at those right now. I want to talk about the sample scenarios. So they have a whole bunch of sample summative scenarios built in here for you. And I'm just, again, it's broken down by population, adult, geriatric, and pediatric. I'm just going to click on this first one. And when I do that, I just want to show you the degree of specificity that we have in this scenario and how it's written. Sorry, guys, my computer's moving slow. How it's written so that it could ensure consistency every time, and there should be no questions. So this is again, it's written for the ALS level or advanced level, but concepts here are what I'm saying we need to apply to our scenario exams at all provider levels. So it tells us the equipment, the setups, there's a background information. It gives us the moulage information. So as an evaluator, I can read through this, and I shouldn't, if I did have questions, certainly I would ask, but I shouldn't have any because it's very clear, it's very precise. And you'll look at, there are several more pages to this. It gives me my dispatch information. It tells me my scene survey information. I mean, if I needed to, I could tell them that, they're sitting at the kitchen table with an open bag of chips and a can of salsa. Okay, it's descriptive, right? And I'm not saying we have to get that descriptive, but the more information that we provide prior to, certainly the more reliability we'll have during the evaluation and more consistency. Again, sorry for scrolling, but I want to show you. So here's the primary assessment page, and this scenario has all these things built into it. If the evaluator needs to provide lung sounds, it tells us here that they're clear and equal bilaterally. If it's not provided, it's not relevant to the scenario. They didn't just leave it off. It's just not relevant to the scenario, and that's okay. But you can see how robust the scenario is. And instead of us, using past practice where we say, hey, I need you to come in and evaluate and go ahead and give me a medical scenario, this is what we should be doing. Okay, this is how we should be ensuring that these guys are well prepared to evaluate, and we're going to have a higher reliability and improvement in our evaluation. I want to take us back here, and just a couple more slides here I want to talk about. So this intra-rater reliability. Okay, so intra-rater, internal, is the extent to which a single individual produces the same result or consistency in scoring given by the same person across multiple instances. So one person who evaluates the same every single time. Okay, so for example, we have an evaluator, and as they continue throughout the day, they would not let elements influence their scoring from one student to the next. So this is not reliability among evaluators. This is internal reliability, that I am going to evaluate everybody the same every time, no matter if it's the first student that I see or if it's the 25th student that I see that day. And there are things that can affect our intra-rater reliability. So labeling and bias. We talked about this before. We've really got to make sure that our evaluators are leaving any bias behind, that they are trying consciously to evaluate each person objectively, and they're not letting any bias influence the performance of their evaluation. Fatigue. Okay, I'm tired. I've been here for 4 hours or 5 hours, and I'm tired. And believe it or not, studies done that show intra-rater reliability decreases over extended periods of time. So what does that mean? How can we improve that then? Maybe knowing that ahead of time allows us to plan for extra evaluators, or maybe I change my evaluators out halfway through the day if I know going into it that I'm going to have a really long exam. Okay. Hunger is another one, right? If I'm hungry, what happens? People get hangry. It's a real thing. And in EMS, we always entice people with food. And if at any time it were ever important, it's this one, right? If somebody's evaluating and they're hungry, believe it or not, that can influence their evaluation. And we could have these entry-level providers who are competent, who are not being scored objectively and consistently and reliably, and we're missing the mark on them. So we want to make sure that we understand what intra-rater reliability is, and that we really take the time to look at these concepts and how we can improve them ahead of time, so that you're not found at the end or the middle of an exam with an evaluator who's hungry and who might not be scoring accurately. So both concepts, inter and intra-rater reliability, I know I'm nearing the end of my time here. Both of these are ultimately going to lead to higher reproducibility of clinical measurement. There is potential for greater student outcomes and overall higher validity in observational psychomotor evaluation. So we need to allow us to determine minimal competencies in the EMS field of practice and focus on improving and achieving higher inter and intra-rater reliabilities. Here's my contact info. So if anybody's interested in contacting me, here's my number and also my email address. I will admit that I am probably fastest to get a hold of via email, but certainly you can always call me, and I'm probably the worst at text. So that is it. I'm sorry, guys, I took you right up to the end here, but certainly if there are any questions, I would be happy to stay here and answer.
Thank you, Allison. So there is one question right now in the chat box. So I will just read it to you. It says, you use the Olympics as an example. However, when they evaluate an athlete, they use several evaluators and a combined score to avoid bias or different interpretation. Shouldn't our evaluations then be done the same way during the psychomotor assessment?
Yeah, that's a great point. It is, but it's not realistic for us to do that. Obviously we don't have definitive resources to say, I'm going to send one student to the a trauma assessment station 6 times so I can then combine the scores of those 6 evaluators. It's not realistic for us. So instead, how can we achieve that inter-rater reliability among evaluators when there's one person evaluating each different skill, if that makes sense, right? So I still want to have inter-rater reliability if I evaluate them in trauma and I have another evaluator who does medical, or what we'll see, when students go through, if they've passed every exam skill station except for one, again, I tell you that stands out to me that we have an evaluator problem. And where do we have a disconnect in inter-rater reliability? I hope that's the question. But if you do have all those resources,